So we go ahead, and it's a pleasure for me to introduce Ernst Holler. Everybody knows Ernst Holler about his work on graft versus host disease. It's a pleasure for me to have him here, and he will speak about acute graft versus host disease, what are the causes and consequences at the cellular level.
So thank you, Dietke, for the kind introduction, and thank to Gentium for inviting me. So what I want today is to talk with you about the classical aspects of graft versus host disease in the first part, and then about the role of the endothelium in the second part. Now, oops. So all of you know this circle of Ferrara about the pathophysiology of graft versus host disease. We have the first phase where conditioning damages the tissues involved in graft versus host disease, like the skin or the gut. In this first phase, we have a conditioning-associated inflammation, which results finally in activation of antigen-presenting cells. We have clinical evidence for this, and I will show you some of the data. So release of TNF during conditioning was an important predictor of GvHD. There are a lot of data showing that higher doses of total body irradiation result in more severe GvHD by more conditioning-related damage. We have less and delayed GvHD in the non-myeloablative setting, and I will briefly mention a recent study where we depleted antigen-presenting cells and also could reduce GvHD. Now, these are the data on TNF release during conditioning. You have here a group of patients with TNF release during conditioning, and the blue ones are patients with TNF release after conditioning. And you can see that the treatment-related mortality is much higher if you have early conditioning-associated inflammation, confirming clinically the phase 1 of graft versus host disease. Now, it's very clear that in the center of graft versus host disease is the interaction of host antigen-presenting cells and donor T cells. These host antigen-presenting cells are activated by the conditioning, but also by pathogen-associated molecular patterns from bacteria, from viruses, and after activation they present the histocompatibility antigens to the donor T cells, finally resulting in GvHD. As I mentioned, we tried to reduce the antigen-presenting cells by prophylactic UVB irradiation of the skin, and here you see histologies of skin histologies of these patients, and we get a reduction of Langerhans cells. This is shown on this slide. We did the UVB irradiation immediately after the transplantation, so we have no strong reduction by the conditioning, but after UVB application you can see a very strong reduction of Langerhans cells, whereas control patients have only a minor reduction. And if we were successful to deplete the Langerhans cells, as shown here, then we do not have early graft versus host disease in these patients. So we have a delay if we deplete the antigen-presenting cells, confirming also in the clinical setting that they are important players in GvHD. Now, in the second phase, these cells, these APCs activate the T cells expand. That the T cells are important is shown, has been known for a long time, and had been recently confirmed by the studies on pre-transplant serotherapy with anti-thymocyte globulin, where Jürgen Finke and colleagues could show that patients receiving ATG have less acute GvHD and also chronic GvHD. An important cellular population which is more and more of interest are the regulatory T cells. This has been shown in mouse experiments by Matthias Edinger and his group. At that time he was in Stanford, now he's also in Regensburg. And you can see here mice who have received conventional T cells. At day 15, these mice die from graft versus host disease. If you combine transplantation of conventional T cells with transplantation of regulatory T cells, these mice do not develop graft versus host disease and survive. And even more important, these mice still have residual graft versus leukemia activity. So prophylaxis with regulatory T cells or strategies improving regulatory T cells is one of the future approaches. And also in the human setting, this is a biopsy study we have done. You can see that after transplant, there is a strong loss of regulatory T cells. One of the most prominent findings, and this seems to be more severe in graft versus host disease. Now, in the final phase, in the effector phase of graft versus host disease, these activated T cells destroy the target tissue. Also, activated macrophages contribute to GvHD, and the final result is apoptotic damage of the target cells by T cell mediated killing. CD4 cells can kill by Fas ligand, TNF, and other mediators. The classical CD8 killing by perforin and coenzyme. But also macrophage mediators like TNF and IL-1 contribute to the GvHD associated damage. This is also shown here from the clinical side. In the old studies, we have shown that TNF release, but also in parallel the release of the soluble TNF receptor correlates with severity of graft versus host disease. Now, we now can question what is the role of the endothelium in this whole process. It's the central tissue in each, the central target in each tissue. It's a first contact for the lymphocytes. And I will briefly go with you through the damage, mechanisms of damage of endothelial cells in the course of transplantation, and then to the potential role of endothelial cells in graft versus host disease. Now, here you see the broad list of endothelial complications, starting in the conditioning phase, as we have heard about veno-occlusive disease. We have the transplant-associated microangiopathy. We have chronic GvHD vasculitis, vascular destruction. And in the old days of GvH pathology, it was very clear that endothelialitis is the first event in GvH pathophysiology. Now, endothelial cells are damaged by conditioning, so we have also the phase 1 for the endothelial cells. Very simple experiment we did several years ago. These are control endothelial cells, and this is a DAPI stain showing apoptosis of endothelial cells of a dose of as low as 4 Gray of irradiation. We have LPS and bacterial toxins in the aplastic phase after transplantation, and if you add bacterial toxins, as shown in this slide, the apoptosis of endothelial cell is increased, so the translocation of bacteria further exacerbates the endothelial damage. Now, this results in activation of the coagulation system. The PI1 has been shown as a very specific marker for VOD. Here is a large study performed in Munich in former times, and you can see that all patients with VOD have elevated PI1 levels, but you also see that endothelial activation occurs in the setting of infection and also in the setting of graft versus host disease. Another marker of endothelial damage is the factor VIII related antigen. Again, a very old study, but demonstrating that activation of the endothelium is a long-lasting process in the setting of transplantation. Here we have patients with severe thrombotic microangiopathy following transplantation, and you can see that these levels of factor VIII related antigen are up to day 180, a very long-lasting process, and only in long-term patients that tend to recover. Finally, the endothelial cells are also targets of alloreactive T cells. Again, you can show this in vitro. If you activate endothelial cells, and here in combination with fludarabine, you get a very high cytotoxicity of allogenic T cells against endothelial cells, and this can be blocked by anti-class 1 antibodies showing that there is a specific alloreaction against T cells. So what do we know from murine models? The group of Marcel van den Brink under the experiment done by Olaf Pennock showed very nicely that neovascularization is another important step in the pathophysiology of GvHD. Now, they showed that increased number of donor-derived endothelial cells are present in the liver and in the intestine of mice with GvHD, and if they applied anti-cadherin antibodies which block the endothelial progenitor cells, they can ameliorate GvHD. This shows the increased neovascularization in GvHD in the liver, in the ileum, and in the colon. And in white, you see the GvHD mice and the cells with positive for CD34, which is a marker for endothelial cells in the tissue, are increased in the GvHD mice. And if you block these endothelial progenitor cells, which result in neovascularization with this antibody, you get some improvement of survival in two murine systems. In blue, these are the blocked EPCs, and more importantly, also the GvH score goes down in these organs if you block the endothelial progenitors, suggesting that neovascularization somehow contributes to the pathophysiology of graft versus host disease. And in line with this, also Marcel van den Brink's group transplanted mice who were absent for P-selectin receptor for the endothelial progenitor cells. And in these mice, you get an improvement of graft versus host disease shown by better survival and by a reduced GvHD score, again suggesting that endothelial progenitor cells play a role in GvHD. We have done some studies asking for the mechanisms of cerebral angiitis, also in mice, and we were very surprised that we can see a GvHD-dependent increase of endothelial adhesion molecules even in the cerebrum of mice. You see the expression of ICAM in control mice, in syngeneic transplanted mice, in allogenic mice, and it was always increased in allogenic transplantation, showing that GvH and the allogenic setting leads to an increased activation of endothelial cells. Now, what is the evidence now in patients? I think that's the most important thing. Can we find endothelial injury? And as I mentioned before, it has been a little bit forgotten in the pathology of graft versus host disease that endothelial damage is a hallmark of early GvHD. This is an old study from 1989, and here the colleagues analyzed the evidence for endothelial damage by extravasation of factor VIII and the infiltration of the endothelial cells with lymphocytes, and you can see that alone from histopathology you see increased endothelial activation also in patients. Later on this was confirmed by increased hemorrhage, in pericapillary hemorrhage in the intestinal graft versus host disease by the group from HSCT in Paris. If you have in the biopsies only mild GvHD, you have no intestinal hemorrhage. But if you have severe GvHD, half of the patient showed disruption and destruction of the endothelial cells with hemorrhage, again confirming endothelial damage in graft versus host disease. And if your graft versus host disease goes on and develops in chronic graft versus host disease, you get rarefication, for instance, of dermal vessels, as shown by Jeanette Biedermann in several studies. A very recent interesting study came out from Thomas Luft from Heidelberg. He asked the question, what is the mechanism of steroid refractoriness and in treatment of graft versus host disease, and he tried to find markers for steroid refractory GvHD, and the most important markers for steroid refractory GvHD were markers of endothelial damage. You can see here the serum thrombomodulin, and it was highly significantly increased in those patients who did not respond to steroids, and also angiopoietin 2, which indicates endothelial repair, is significantly increased in steroid refractory GvHD. So he came out with a model that in treatment-sensitive GvHD there is no endothelial damage and there is no perpetuation of the tissue damage by endothelial lesions, but in steroid refractory GvHD you have additional endothelial damage, and this perpetuates the damage from graft versus host disease. So we can summarize, we have different phases where endothelial cells play a role in graft versus host disease. In the first phase we have the conditioning related damage, and I should mention this is a slide from the very nice review by Marcel van den Brink's group and Gerald Saucier. So we have the conditioning associated endothelial damage, which results in very rapid neovascularization by donor endothelial progenitor cells, and if this neovascularization is very rapidly, you have better influx of donor T cells, which contributes to accelerated graft versus host disease. And finally, in the effector phase of graft versus host disease, and I've shown you in vitro evidence as well as in vivo evidence, these donor T cells also attack the endothelial cells and further contribute to potentiation of endothelial damage. So we can summarize for GvHD, we have still the most important pathophysiological event is the interaction of host antigen presenting cells and donor T cells. I have shown you that we have multiple causes of antigen presenting cell activation, like conditioning, but also bacterial and viral ligands. It's getting more important that not only the effector cells are relevant in graft versus host disease, but the balance between regulatory T cells and alloreactive T cells. And I think it's especially important in the effector tissues of graft versus host disease, like in the gastrointestinal tract. There are very interesting new data showing that these cells decide whether GvHD develops or not. Now, all these mechanisms of activation are also relevant for endothelial cells. I've gone through the different phases, the conditioning phase, the alloreactive phase. They all contribute to endothelial damage and neovascularization and T-cell mediated damage. is a consequence of this and contributes significantly to the pathophysiology of graft versus host disease. And this is just to mention the co-workers at our center, Selim in the Department of Pediatric Hematology, and we have also a close collaboration with Enric Carreras, and I thank you for your attention.
So please use the microphone and ask questions. If not, I can start. I like your slide about the endothelial damage. You are one of the pioneers of endothelial damage. I remember 25 years ago you already spoke about endothelial damage. Do you have, or how can we mitigate this damage? You have used some in vitro data, or you have some in vitro data?
Yeah, we have. I haven't shown it for the sake of time. Of course, we were also interested in defibrotide as a drug reducing this apoptotic damage, and indeed, one of the mechanisms is an anti-apoptotic effect on endothelial cells. And it's also interesting, you can, as shown by Enric, you can also downregulate the adhesion molecules by defibrotide, so you can interfere also with the alloreaction of T cells if you apply defibrotide. This is true now in the experimental models, and of course we have to demonstrate this also in the clinical setting. There are not a lot of alternatives for modulation of endothelial cells, and I think an important aspect which has also been mentioned by Enric is that we have another player which makes the situation more complex, and these are the calcineurin inhibitors, which prevent endothelial repair to a large extent. So the setting, how we perform transplantation at the moment, is predisposing to endothelial damage. And even the steroids, we had the question about steroids before, they further add to activation of coagulation and to endothelial damage.
Professor Holler, could I ask a question about the...
Use the microphone, or you can use my one.
Professor Holler, thank you. You commented about the use of ATG in reduction in GvHD. You didn't comment about Campath and its reduction in antigen-presenting cells and how that may affect GvHD and VOD risk.
Of course, T-cell depletion in general, I said T-cell depletion in general reduces graft versus host disease, and this includes the Campath, which does a very strong T-cell depletion. To my knowledge, it has not been demonstrated very clearly that T-cell depletion reduces VOD. We have the situation that unrelated donor transplant increases VOD, so the alloreaction contributes to maybe also to the early endothelial damage. It has not been proven in the studies with T-cell depletion that it's right the other way around, but this was also not in the focus. Endothelial damage was not in the focus of the clinical trials.
Do you think it's true? I mean, you presented quite nice data on UVB protection by irradiating the skin, but yeah. Campath also takes out dendritic cells from the gut, which may repopulate the skin and also act as the first point of call for
this might be one mechanism why Campath is so effective in preventing graft versus host disease, but APCs, I think, not directly relate to endothelial damage. The question even is whether endothelial cells can supplement APCs in presenting antigens, and this would be not affected by the strategy.
Further questions?